today's webinar. It is with great pleasure I like to welcome a fantastic person that I met recently in Leeds, Nurse Liliana Cocis, or I'm gonna call you Lilly today, I guess.
Yeah.
I was a senior therapeutic endoscopy nurse who works at the St. James University Hospital in Leeds, NHS Trust, and she's been doing this for a long time, and I am very excited to hear about you and from you let's say the blind spots that many of us endoscopists and physicians in general have in our knowledge in terms of what you do in your everyday. So thank you so much for joining me, Lily, and welcome to today's webinar.
Thank you very much. Thank you for inviting me and giving me this opportunity, to share my thoughts and my ideas, about what a therapeutic endoscopy nurse can face during, a complex endoscopic procedure. So thank you so much for that.
Very nice. So, what I'd like to spend this session almost solely on is let's assume that we're watching a therapeutic list together, and we're taking it from before the patient walks in until the room is turned over, and see that day through the nurse's eyes. So my first question is about the role. So if we start here, you think about your role in the unit as an endoscopy nurse. So how would you describe the role? Not like the HR kind of job description, but in your own words, what is your job as an endoscopy nurse in the room?
So obviously, as my main role in endoscopy in the procedure room is I have to focus on patient safety. Okay, so this is my main role. I need to know, the patient is safe, I offer him comfort, and away of anxiety, and just offer the dignity and everything what the patient needs when he comes into the procedure room. To focus on that, there is different responsibilities. Okay, so first of all, let's say in the procedure room, as a nurse, there is a team, but should be a leader of the team, which is coordinating in the room, okay? So all the team in a procedure room, you need to make sure that they are competent enough, in the patient care, in the patient's safety, to monitor the vital signs, and to act promptly in kind of emergency situation. So you need to make sure that everyone is competent and skilled in that kind of situation. Then comes, the situation like the staff and the team in there, they are aware of what kind of procedure they are going to undertake. Okay, so what kind of procedures, what the need, and what is the responsibility and everyone's roles between the room. So before the patient comes in, before the procedure starts, there should be designated roles for each room. Usual, we should have 3 members of staff in the procedure room. So one member of staff should have focus on the patient side, like monitoring the patient, assuring the comfort, be patient advocate when needed to, maintain dignity of the patient. The other 2 staff should be focusing on scope side, let's say, or working alongside with endoscopist. So these roles should be very clearly distributed before the patient comes in, before we start in the room. And then gather the equipment. So identify the procedure, what we need to do. identify the patient when he comes through the door and have the procedure. Okay. Gather as many information as you need regarding the patient past medical history, mobility, like disability, patient awareness, infection control, also anxiety of the patient, and also I would probably say religion as well. You know, it is very important, you know, to have all this information gathering for the patient. Mm-hmm. Once we've got this, as a nurses, now we know what to do, what kind of procedure it is. So in advance, before the doctor comes into the room, we should gather the main equipment which we need. And that is including the scope, which we assuming that the doctor is going to use it. However, we have to be aware that in many situations when a scope, probably the doctor wants or prefer different type of scope, or during the procedure wants to swap the scope, we should do that in advance. We should make sure that in department we do have the scope needed, a therapeutic scope, and any type of scopes aside, ready. Inform the staff in a decon that the scope is ready for that. And then gather the equipment needed. Now, I would probably say, despite of the fact that we spreading the role to the staff, you know, and they know what kind of their roles between the room is, all together the staff should know what kind of equipment should get ready, where is it, place it within your reach, you know, like hand reach, you know, very easy to get it. So everyone, not even like the scope side staff, but even though the staff was looking after the patient, should know all the equipment needed. It's very important to the environment, so make the environment safe for the patient, safe for the staff as well. Take in consideration that the procedure, the complex therapeutic procedure, they can take long, okay? Yeah. So make sure staff is well prepared. That means hydration and other things which you needed before you starting the procedure. It's very difficult after that to leave the room because you're responsible in there. You should be in there. Another important role for the team, the staff in the room, is to identify the emergency call bell. What is it?
Yeah.
Kind of situation.
Yeah.
Emergency cupboard and the emergency equipment should be ready, should be in date, and should be there, you know, and you know what is it, and to find it when you need it. So that is probably before the patient comes in and probably before the endoscopist comes into the room. Then when the endoscopist comes into the room, you have a briefing. You're discussing about the patient. You're discussing the equipment which you need to have it ready. And then that when we are all set and it's all ready, we are agree and between a communication with endoscopist, we're saying that we're ready, endoscopist ready. Then after that, they bring the patient in the room.
I think like, I mean, this is fantastic because, like, I mean, right now you answered the first three questions that I was gonna ask you right off the bat, which is, I mean, just showcases how like how you are really like a master of your craft. Like you know, you have this like in your in the back of your head. You know exactly the steps that you need to think about. And you know what's important for many, I think, for many physicians and endoscopists to know is that a lot of this is happening behind the scenes. We're not even in the room yet. And you're already doing, and this is happening every day in every endoscopy unit. You're doing all of these things. You're preparing all of these things. You're dividing the roles. You're making sure that the equipment is there, and the scopes are there, and how the room is looking, and which doctor you're working with that day, and so on and so forth. And all of this is happening while the doctors are still just probably changing in the changing room, right? They don't even they're not in the room yet, or maybe they're just walking into the room and they're just like, saying hi, good morning before you even do that timeout that you spoke about. So, I mean, I think if anybody is listening here who paid attention carefully to what you said, most of us can already see where our units are strong or weak, depending on some of these things that you said, because a lot of us can identify some of these things that we're already doing, but many of the things that you said are not being done. And you've mentioned very concrete things that the nursing staff should go through. And if someone is takes what you said today and just take this part of this whole webinar and just turn it into a printed checklist on the wall that they would have in the endoscopy room, I think they would already remove a lot of the chaos that can occur in the middle of a therapeutic case. So I really appreciate that. So let's say now that we've rolled, it's now it's around 8 a.m. and we've rolled the patient in the room. And as I told in the beginning, we're just gonna go make this like a story. We're going through our day together. We do this every day, but every day is kind of different. Although it may start the same, but it ends up differently, right? So let's say now the patient is in the room, and we have made sure that everything is ticked before we even insert the patient, the scope inside the patient. During that timeout that you do with the physician and the team before you start, from your perspective, what are the most important aspects that the nurse specifically needs to pay attention to, as well as the rest of the team?
In our timeout.
Yeah.
Like before we start.
Right before starting, when the anesthetist is there, the nursing staff is there, the doctor, the fellow is there, and we're discussing Mr. Johnson, who is a 65-year-old male who has, let's say, a rectosigmoid lesion that may or may not be an ESD or EMR or a hybrid or something like that. So what would you want to know, and what information you would like to deliver to the rest of the team during that timeout?
So basically, I think like in a timeout, so we have to communicate the patient's risks. So what's the patient's risk, what's the patient's benefits, and type of procedure, probably, and the length of the procedure might be a problem.
Mm-hmm.
I'm quite sure the roles, of who's working with. And I think I probably said before the equipment needed, and if it's equipment in date, and if you are familiar with the equipment, many times, we do. So I would probably say, if we know the type of procedure we're doing, let's say in a EMR or ESD, I'll get the equipment out, but alongside with that, I'll just get more, which I predicted that it might be necessary, so I'll put it aside just in case. And also I will just make sure that the emergency equipment is ready or perforation.
Right. So now we have this. Now we're ready. We check the scope. We're ready to go. And then those first minutes from scope insertion until we get to the lesion, let's say, and we're about to start resecting or dissecting. As the lead nurse in the room, what are you paying attention to, and what are you preparing in the background? are you awaiting, like, do you always like anticipate, okay, I'm gonna, or you're one step ahead, as you said in the beginning, you have everything ready, but now I have the lesion right in front of me. Do you start, like, are you priming your, let's say, your injection needle, and you're getting your
So,
stuff ready, or you just looking, making sure that, okay, just standing there and
no,
waiting for, or what's happening in your head?
okay, yeah. So yes, obviously we priming, so we predicted. Obviously, you don't know, as you said. It might be MR, it might be SD, it might be hybrid, it might be, However, we do have the basic equipment needed ready. So the needle primed, you know, just for injection, the probably some infocol for washing, and
Yeah, of course.
yeah, for washing to clear up and to have a proper view of the lesion. I would probably say snares or a knife for ESDs. I will have it there, but I will not open it yet. We have
Right.
to, so the doctor need to assess the lesion first before they will make a decision.
Right.
But have it next to me ready. Also, the machine,
Yeah.
should be ready, and also with the settings on. So kind of like we know for ESD what type of procedure, we know the settings, and we just like setting the device, accordingly. And scope ready. So we don't wait. No, scope ready and waiting, to be used.
So if you zoom in on the critical moments now, this is like, injection, cap cutting, hemostasis, because if we understand how you think around those steps, we can train our own nurses to do the same thing. So if you take a typical EMR, just before we inject, or just before we snare, and just before we deal with the bleeding point, what are you doing and thinking? Now we have like the lesion decided for EMR, and we're going for it. What is your choreography?
So let's say it's a lesion and we're doing EMR, okay? So I'm getting ready. As I said, there is basically should be two nurses on the scope side. One nurse working alongside with endoscopists, be ready with the hands on. Another nurse on one step behind, watching and getting ready the equipment. Both of them, they should just think in advance. So if I'm looking and I'm just thinking like there is going to be an EMR, I've got the solution ready, I've got the needle ready to hand it over to the nurse. And then I'm just looking at the screen, predicted, the size of the snare needed, or what kind of equipment is needed. Get it out in advance. Do not open it until the doctor commands, the endoscopist commands, but have it in your hand. Have the coag graspers ready, just in case you're watching, you're seeing there is. So it depends on the position of the lesion. So if it's a sigmoid, rectal, or even like further up, you kind of know where is quite a lot of vessels, where to expect, bleeding, and have it ready. Have it ready and the settings in your head. Think about the settings need to be done ASAP. Once you see the bleeding, you do the setting, you're handing over, the endoscopist, the equipment needed to stop the bleeding. So, yes, I think that's kind of like be ready, be prepared, and ready to act in case of complication and emergency.
To digress a little bit from this, Lily, you said you always have like the three nurses in the room. From your perspective, you mean only in the case where you have a planned therapeutic procedure, or like do you think this is like should be the case? I'm speaking about like best case scenario. I know staffing can be a problem and timeline and everything. But let's say in a best case scenario, do you think you should have three nurses for every type of endoscopy procedure, or only when you have a therapeutic one?
I would say therapeutic one.
Therapeutic one,
On a
yeah.
basic endoscopy, I think will be enough, like 2 nurses. If it's ideal, 3, for one just to help around. However, for my advice, it should be 3. I know it's not always possible. That is how you maintain safety. Environment also, and patient, I can't say more than that. Patient safety is 3.
I fully agree with you. It's like to have, if you have a therapeutic procedure, you should always have 3 nurses. And when you have let's say a screening procedure or something like that, 2 nurses enough, but you need to have one standby that you can just press a button in the room and they can just run in to help you, with something that you need. I fully agree with you on that. I mean, because once you're doing therapeutics, it's difficult to run the show smoothly only with 2 nurses. And I think it's quite important also to engage the fellows. There's always fellows in these rooms when we're doing therapeutic procedures, or some of our slightly junior colleagues who are also learning. They can be doctors themselves. And I do my procedures, I always make sure that I actually engage them in that part as well, not just in watching and describing what's on the screen and talking about the technical stuff, because they must, I think an endoscopist needs to understand the tools. They need to understand the electrosurgery settings. They need to understand, they need to be able to troubleshoot the processor if something is not going right, and I think during that stage of being a fellow, I think it's very important for the fellow to be engaged in that, and also to listen to some of the prompts from the nurses, because I think Tom was actually telling me this when I had my webinar with him. He said his in the first year, he used to always watch your body language and listen to your not actual sentences, but when you hum about certain things, and that's when he knows that okay, she's not happy with that little movement, I should probably do it differently. And I think it's very important that you guys have the courage to actually speak up, especially when a fellow is on the scope, because you have seen things go right and seen things go wrong. So what do you think about that? Because a lot of nurses are apprehensive and hesitant. They don't want to speak up because of the hierarchy and whatever. But I think you guys should do it all the time, really. How do you feel about this yourself?
So yes, I think you're right. However, as a nurse, obviously you kind of probably that, so we are, from my point of view, I know we are nurses and I know we are very important. However, from the beginning, I always looked at doctors and endoscopists, because obviously you do have the experience, you do have the knowledge, and you do have, the training, higher up. So we always, we have kind of we're looking up, let's say that, have this respect, which is true. And I was the same thing, when you're starting in this kind of procedure, you doubt yourself because you don't know if you're right or wrong. You don't know, you just learn in time. You learn a lot with the endoscopist, all these probably challenges and what to do in case. So at the beginning, probably you don't have that feeling, to speak up, even though everyone tells you speak, to speak up opinion, but probably you kind of you're not sure on yourself. You don't trust yourself, on that. In time, you gain this kind of experience that doesn't make you that you know everything,
no, of course not. Yeah,
it doesn't make you that, but you do have this that fear is going kind of easing, and you can speak up, you can give your opinion. And also I think it's very important when the doctors is kind of what do you think, that kind of what do you think? It gives you, you know, that confidence that, yeah, I think I've got this opinion and I can express, you know, my opinion, you know, more freely without you judging me.
Yeah. Okay. This is very important. So so you're and I think I feel that I've actually felt that, and I fully agree with you. I think if there's this there's definitely this fact where nurses, they look up to the doctors, and they don't want to, let's say, place sometimes, because they don't know how the person would react maybe. But if I would advise, like, probably physicians or like endoscopists to always, kind of include the nurse in that, thinking out loud, and asking, what do you think about it? And that, I think, will give you the courage to actually speak up and say what you think without feeling that you're being judged. Exactly.
Yes.
This is really
Yes.
wonderful said. So everybody who's listening, just make some notes, because I think this is very, very important. We should definitely be more vocal, because I was told, I remember when I was training, and I'm still training every day on different things, but like in the beginning of my journey, one of my senior nurses, she used to always tell me to stop mumbling, because I was speaking to myself as I'm, like, trying to read the polyp and what I want to do with it. So I was mumbling, and she couldn't hear what I'm saying, so she doesn't know whether I'm giving her a prompt or just speaking to myself. So it was like, Sam, stop mumbling. Tell me what you're thinking and what you want, so that I'm with you on the same page. And then when I started spending more time in the room with other endoscopists, I noticed that it's really common that many endoscopists, they just mumble.
Yes, indeed.
And the nurse is always like, do you want what you wanted something, or what is this? So it's interesting, I think.
It is interesting, and it is happening.
Yeah.
But more you're working with endoscopists and you know them, the more you kind of, it's not guessing, but you just like know the next step. Kind of, so you do, and you can ask also, but that also, as I said, you need a little bit of time. If you're starting to work with an endoscopy, start to work in the room, there is not too many nurses, let's say vocal, which can they express themselves, very easily. They're not. So you do need a little bit of time, and probably that's why you need a lead nurse, a senior nurse with you, to give that kind of confidence, grow this confidence, and you got feedback from an endoscopist, then it's much easier.
Yeah. If we now switch gears to slightly more complex procedures like an ESD, let's say, and where there's more steps and more things that can go wrong, how does that change your, let's say, internal script? What are the key transitions you prepare for? You talked about like having the coa grasper and having, like, things ready, but is there something else that you kind of keep in the back of your head when you're doing, let's say, ESD compared to EMR, compared to POEM, compared to FTRD, or do you kind of like have the same mindset about the procedure regardless of the selected therapy?
No, so all these, as you mentioned, so all these are complex therapeutic endoscopy. However, keeping in my mind that endoscopy mucosa dissection, so ESD, is a little bit longer, so it's always you're thinking about like time frame. So I always think, especially when it's afternoon procedure, I'm looking in advance on the referral and just like just trying to figure, the size of the lesion or so. So I do in the back of my mind that might take longer. That might take longer after my finishing time, after my colleagues' finishing time. So we have to get prepared for a late finish. Or if there is only like commitments for the staff, like childcare or anything like that, I go with the coordinator, with the manager, and say like, look, if it does take longer, please make sure that I have staff to come in a time like finishing time, just to come in and take over just in case. Me as a senior, as a leader, I tend to prepare myself and to stay behind. Do not like to go home, to leave the procedure, and then to because there is always, if I'm leaving and going home, it's always thinking like, is everything okay? The patient okay? Have they left? What time they left and everything? So I'd rather stay there. I'd rather have this time, to just spend it in there, say until until procedure is finished and the patient is safe and the recovery is safe recovered, and just like leaving the department safely.
Very nice. So if we like zoom in a little bit on this, so no matter how good an endoscopist or a team is, we'll always be seeing some bleeding in a therapeutic procedure. Question is not like if, but how do we respond to this? So if we say, let's say we're doing an ESD or MR and then we get some fast brisk bleeding.
Yeah.
Can you take us through your first, like, let's say 60 to 90 seconds?
Okay. So if you have a vessel, so it start bleeding, so sometimes the doctor wants to stop the bleeding, if the vessel is not big enough, just to stop the bleeding with the knife, closed knife. I'm using the soft coag settings. However, if the vessels is a bigger size, then obviously you get a grasper, and obviously change the settings to a soft coag, and then you just hand it over to the endoscopist. Probably sometimes before the endoscopist can ask him, have you ready? Hand it over for the endoscopist.
Yeah, and these things can become so quite like when you get this brisk bleeding, can they become quite fast, quite hectic, and that switching like the electrosurgical setting is very important and must be done and not missed. Of course, the endoscopist sometimes can change it him or herself with by pressing on the foot pedal themselves, like depending on the model of the machine they're using.
Yes.
But how do you do, like, do you have like a sequence of doing this? Like, do you always like you open the coag grasper or like any hemostatic forceps, you hand over to the endoscopist and then you go for the machine, or is the job of the other nurse?
So depends. I trained my staff. So basically, as I said, if we do have 3 nurses and one is looking after the patient, 2 other nurses is just staying behind the endoscopist. One is hands-on, the other one is behind. That one, the role of the other one, the third nurse, is extremely important. So that third nurse is basically, her role is get ready the equipment in time, in advance, look at the screen, get ready the grasper to the hands-on nurse, and also changing the settings. So her role is to change the setting, because you as a hands-on next to endoscopist, you're focusing on that. You just like pulling out the knife, trying to hand over the coag grasper. So you're kind of busy doing these things while your colleague, the other nurse, is changing the settings. My is, as a hands-on nurse who is using the knife or the coag grasper or the injection needle, please make sure, even though your colleague and you trust your colleague, make sure that all these settings are changed before you're actually doing the procedure,
Right.
So look at the screen, settings is ready, just go. Sometimes probably the other nurse has no time to change the settings. Doctor's got ready because he's busy, he's quick, bleeding, wants to do it. You stop the endoscopist and say, stop, the settings are not ready yet. So basically, you have to say that. Even with the injection needle, when you're injecting and the syringe is empty, or you need to swap the syringe, you have to communicate to endoscopist clearly, I'm swapping the syringes, I'm changing the settings, I'm giving you the coag raspers when it's ready. So all these which you need to do it, you have to communicate with the endoscopist. The endoscopist so you have to remember the endoscopist is not looking at you. He's looking at the screen, he's looking at the patient and at the screen what you need to do. So that's why the communication between the nurse and the endoscopist should be extremely important.
Yeah. Amazing. I mean, this is something that any unit can rehearse in simulation, right? And if every nurse knows the sequence, I mean, the whole team's response becomes much faster and more consistent. Because I think this is one of these moments. I mean, that and perforation, these are the two moments where like things can become quite sweaty and where emotions run high and where it becomes really dangerous for the patient, right? I mean, we should not forget the patient that is the center of our attention. All of this, we have a human right there on that table that we're working on.
Yeah.
And then all of this revolves around their well-being and and to avoid any complications and the shortest stay in the hospital. And especially like when we're dealing with, especially when we're doing like these complex therapeutic procedures. I mean, the reason we're doing them is as an organ preserving procedure so that they don't have to undergo a big surgery, but also as a procedure that will shorten their hospital stay, will enable them to retain their quality of life like quickly. They don't have to do rehab and whatnot and like, be away from work or like, the gym or their hobbies for like, 6, 8, 12 weeks just because they're recovering from a surgery. So it's important that like, we always rehearse these aspects that can lead to the patient actually ending up in an unnecessary surgery, right?
Yeah.
So I fully agree with you. And and this is a segue into the other horrible thing that can happen when things go wrong, which is perforation scenario that we all fear, or the moment where we may think that there is a perforation there. In that situation, what is your mental checklist? Well, what happens in the first minute from your side?
Okay. I think you do feel your heartbeat in that moment. Okay, so definitely you do feel that, and probably his heartbeat too. But it's very important to keep calm, to stay as calm as possible. Think about what do you need to do, in terms of like for the patient safety. So as long as the endoscopist should be calm with a calm voice, to give you orders, and also need to be calm to know. So in that moment, obviously, you want to do it and you want to act promptly. Do not
Mm,
rush. Rushing, something goes. Be calm.
right.
Think about what is your like training, what you've been trained, what do you need to do, what do you expect. So all these, and also like obviously the nurse on the patient side, so you need to just like make sure that the patient is safe.
Mm,
um, Observation, airways, everything, to be on a safe side while you're
yeah.
acting on the other of the and to close the perforation.
Right.
Is
Mm,
very you as a nurse, and if you think that the endoscopist is calm and gives you like order calm, and asking for equipment in a calm manner, that helps you as well, to be calm and say like, this is it, we can do it,
right.
everything is
Yeah.
fine.
Yeah.
Fine.
Yeah. I think it's the worst thing if the endoscopist loses his or her cool. I think that
Yeah.
kind of sets the whole room into a spiral where things uh
Yeah.
can become a quite sweaty. And I think this is why it's important, like when somebody is still not confident enough in doing therapeutic procedures, even small ones, they should always have like a senior in the room around them, or at least a senior close by, where the
Yes.
nurse sometimes, like I remember one of my senior nurses used to ask me when I was doing any, like even when I was doing something that is as
like as simple, something that is as, let's say, as basic for an everyday endoscopy, for therapeutic endoscopy, as like banding of esophageal viruses that are not bleeding. The standard esophageal virus, which should be uneventful. But sometimes they may become very eventful. But even during these procedures, remember, I used to be told I asked by my senior endoscopy nurse uh, whether she should call in a senior to be in the room while I fired the bands. And I really appreciate it, because I wouldn't have done it myself unless being prompted to do that. So I think that's like something that is also important for nurses to sometimes point out. Maybe don't
It
cut that vessel if you're alone. Maybe have somebody around you. Uh,
is very important. Yes, indeed. We do think like therapy, like acute bleeders in an acute inpatients list. We are doing that, so we do have a senior nurse in there, and also we tend to do like in complex therapy procedures, a senior nurse. But also what we're doing, and I think is very important, is like before we starting, we communicate with the nurse in charge, the coordinator out there, and say we're ready, we're going to start the procedure now. So they are aware about the time frame, and now and again they're just coming to check on us, to check if is everything okay, if we need anything, and if the patient and the procedure goes okay.
mm,
And I think is extremely important, because we know that this kind of complexity can take long.
mm,
So we need to communicate to the relatives. So sometimes
mm,
the nurse in charge or the manager
mm,
just get an update from the procedure room, from the patient, how far he is, how we doing, and then communicate with the relatives, because the relatives can get more anxious than the patients.
yeah, yeah, surely, surely, yeah, absolutely. Um, if we now shift gears a little bit, and let's say we move from being the learner to being the one who trains others, like in your shoes right now, that transition is important for many units that want to build a sustainable, like, therapeutic service. So when you look at a nurse and you say, uncomfortable having this person with me on therapeutic lists, what objective things or characteristics have you seen that make you say that you think this nurse is now ready to be with me in the room and I can rely on her or him?
So me as a trainer, okay, I do have a couple of steps. So I do take. So, did you ask me like how confident I am to work with someone else in the room? Like, is kind of
Y-
no.
Yeah, like you've trained somebody, you've been somebody that was a junior, and you've been training them for a while, and now, and but they were always like as an accessory in the room, like as an additional person on top of your standard two nurses that are with you, and there's a fourth one. When do you say, like, okay, now she can replace one of the two that are in the room, and you're okay with that? What, like, let's say, what milestones would you need to see in order to actually feel that way?
Okay, yeah, I understand. So obviously, that nurse who's coming and starting to train in a complex procedure, they should have the basic of endoscopic procedure clearly, and to have the basic, like in probably, so to start doing some EMRs, and then attend the room, observe, understand
Ah,
the
mm,
understand the procedure, understand the type of the procedure, and observe the equipment. So that
mhm,
is what they need to know. I talk through with them, so I showing them all the equipment. I actually let the staff play with the equipment. I always have like a box with the complex accessory, for the complex procedure there.
mhm.
I show it, train them, tell them in what kind of procedure it need to be used.
Yeah,
Also, when the times allow us, we playing with a B machine with a
nice.
like, yes. showing and just changing the settings, like kind of the settings, for each procedure and how do we change it and when to change it. Obviously they should have some knowledge, like theoretical knowledge about the endoscopic procedure, the benefits, the risks, the complication, and what to do. Once that, and they attend the procedure, and a couple of times as an observer, slowly I integrate them in step by step, be probably the third person to have equipment, because in that way they know the equipment until probably I am confident enough, but that is me being confident, to hand over, the staff, and to just be there next to the staff, when is working alongside with the endoscopist. But also I need a feedback from the endoscopist. So once he's doing and just work alongside with the endoscopist, at the end of the procedure, we always have a debrief, a discussion about what good, what gone wrong, what do we need to improve. And that is where feedback, so between endoscopist and probably the leader in the room, they will say, okay, that's okay, so you're doing good, probably you can be signed off in this kind of procedure or this kind of procedure. So it's always with the endoscopist when that staff is ready to work and to become.
So some sort of almost almost an educational contract, really. I mean, you need the nurse to know what she's doing. She must have observed, must have played around with the machines and the equipments, and it's something that can make actually building competency into a checklist, an objective checklist, instead of just saying that this person is experienced or not experienced. I think this would make it much more objective. I don't know if all units do it that way, though. I think many units, they just have nurses observe a certain number of procedures and then they're just left on their own, which may actually lead to frustration, I think, because the nurses themselves, they feel that they are not confident enough to be left alone. Or you get an endoscopist that starts becoming upset about having, let's say, a nurse that is, less ready, let's say, than the one that he had in the room with him before. I think this is really important. In terms of the relationship between the endoscopist and the nurse themselves, this is where a lot of frustration can either be created or avoided, I can imagine. And I'm sure you have had your share of those over the years. I'm sure you all have our people that we love being in the room with, and we have people that we are less to be in the room with. And we're just humans. I think it's just natural and normal to address that issue. So as Lily, the therapeutic endoscopy nurse and a senior nurse in the unit, what do you need from us as endoscopists, and what do you think we should be expecting from you in order to have a relationship that would thrive?
I would probably say communication, respect, and get involved in training. Is very important, in different type of training. And nowadays, when loads of the innovation, the equipment, everything is just come up, it's loads of new equipment is coming up, so probably the doctors, they do have more possibility to get trained in, or to see this. We as a nurses, that we don't have as many as opportunity, so we just oh, we've got this equipment, let's use it. It's because we need to understand, the type of equipment, how to use it. We should have a little bit of, let's say, playing up with it, just to see how, because we are the staff who's using it.
Exactly.
So we more involved in kind of like handling. So we like it kind of technical skills, which we develop quite a lot.
I fully agree with you. Where I think physicians and doctors should be more engaged in training nurses in, like, workshops, symposia, courses to go through all of that step by step, and to ensure that we're like kind of speaking the same language. I don't think it can be expected. It doesn't happen just automatically, I mean, this must be taught. I think it's important that the nurses hear also how the doctors like to communicate, and vice versa.
That's
So
true.
this can happen only in some sort of like a workshop or symposium or a course or something like that. You cannot do that during like a list or in between lists. It's very difficult because you have the pressure of needing to produce. You need to finish your procedures. You need to do your admin. You need to clean. You need to clean up the room. You need to put the scopes away. You need to check the stock. All of that. This is impossible to do everything, all of that, and then do some additional training. So I think every unit where they have any service, and I don't think it needs to be very advanced kind of endoscopy. It can be even like, let's say, standard endoscopy. They would benefit a lot from actually just organizing something that is just local, where they would actually be talking about the tools that we use and why we use them, why we choose this over that, why we do this setting and not that setting. So that it's kind of like, it's just like kind of ping pong of ideas between the two categories that can improve definitely the outcome for the patient, right?
Yeah, that's true.
No, no. Um, Very nice. It's fantastic. Really, really cool, Lily. So if you had like, that's like a final thing that I want to ask. If you were to give one message to endoscopy teams who want to improve their therapeutic lists, say not with new gadgets, but like how they work together, and how they perform, and improve the quality of their unit. What would that be? What would your advice or message be?
For the nurses.
Yeah.
So first of all, always focus on a patient safety.
Mhm.
Learning, take part in a simulation, communicate with the doctors, search, do a lot of search, and just be willing to learn and to like
Mm.
it. You need to
Search
like this.
search for what? So what do you search? This is a really nice. I really love that choice of word, because it shows also like that you're really keen to learn and keen on learning new things. But what do you have in mind when you're telling nurses they need to search? What do they need to search for?
So a search for what I am doing now and again is like, probably say, I don't know if it's good or not, but just Google it.
Yeah.
Different like
Yeah.
procedures, Google it, looking at devices, looking at different type of procedure, how they using it, so now the Google, can give you loads of information. Probably, so get what is good for you, what is
Yeah.
useful for there.
Yeah.
And also, like asking. Sometimes I do ask, the doctors, but sometimes they're too busy, to ask for different type of. So I'm trying to do my own research in kind of
Yeah. Yeah. Yeah.
procedures.
Yeah, yeah. It would be amazing if like, all endoscopists are like, can actually operate and talk at the same time. But many endoscopists, they can only focus on one thing at a time. Uh, but I think the nurses should ask questions when they have them. And as you said, certain things you have to read on your own. And I think, since, I mean, we're talking about intelligent,
You
highly
have
educated people, so they can actually sort out the good information from the bad information on Google, right?
exactly, and sometimes you are just in a situation because probably you don't know that, so you are asked about like the new starters or the team, from and the nurse is like, what is that, why are you using for, they don't know. So you have to provide them with an answer. You are the leader in that, so basically you training others. So you have to come with an answer why. I cannot say like, oh, just go to the doctors, and ask, or the endoscopist, and ask the endoscopist. I need to search, I need to find out, and after that, I need to explain, why I'm doing that,
Yeah,
what comment is it, and how can you use it is, and why I'm using it. So
yeah.
that's what kind of like
Fantastic.
responsibility.
Yeah, fantastic. I love that. But that's where the motivation comes in. It comes in. I tell my staff and my fellows and even nurses, like I can talk a lot. I can give you my time. I can give you the tools, but the motivation always comes from here, right?
Yeah,
That's
yeah,
that's that's uh, that spark, that fire. That's always from inside your soul. You feel it, and sometimes you can help people to just like ignite it so that they can actually fall in love with that thing. But at the end of the day, I think we all have our 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 part, our responsibility in learning, and that's I think that was really well said, Lily. So that's a good way to end. It's not about heroics in the room. It's about like preparation, structure, and definitely high level of respect for each other's role in the room. I think this is very important that we show a lot of respect and gratitude for each other because we all work as a team, as one unit. I don't think we can function properly without having those factors. So Lily, thank you. Really, thank you so much for walking us through your world. And I hope a lot of units will translate what you said today into their own checklists, drills, and daily routines because I think that would end up benefiting our patients and help saving lives in the end. So thank you very much for taking the time and for your efforts, and I wish you all the best of luck in your continuous endeavors. And I really look forward to coming back to Leeds to spending some more time with you in the room.
Thank you so much for inviting me. Thank you, and yes, I hope I probably just a few things and just ideas will be useful, for the nurses and for the endoscopist as well. Thank you.
I'm pretty sure. I'm pretty sure. Okay, Lee, thank you so much. Have a good night and see you soon.
Thank you very much indeed.
Thank
Thank
you.
you.
Bye.